A warm welcome from Sama Resource Group for Women and Health and Gender Justice Health Thematic Group of People's Health Movement Global. To all of you, the speakers, Dr. Prashant Kidambi and Dr. Carlo Caduf, and our facilitators, Professor Aditya Bharadwaj and Professor Rama Baru, and also to all the participants who registered and who are attending today. And many showed a lot of interest, and then we will be sharing with them the recording. Most of them could not participate because some of them are from South America because of the time constraints. We couldn't, have them today here. At Sama and at the People's Health Movement, our work around COVID-19, it wove around our engagements with community action, research, advocacy, monitoring, and also education. So our initial work, which emerged from our work around COVID-19 during the past 1 year, much of what we did in consultation with many of you who are attending today, whether it talking about science ethics part of the entire COVID and later on the vaccines, and talking about the other issues related to the equity and intersectionality, particularly in the context of marginalized groups, and having conversations with frontline workers in our country and also in some of the inter-South countries too. We are having these regular conversations, not only at the community level, even at the South Asian and particularly in the global South. And yeah, much has been talked of the many experiences through the year of fear, of pain, of loss and destitution. The world has suffered together and apart. And later on, the vaccine rollout and the access and distribution that became another major issue. So as 2020 rolls on and the new decade begins, 2021, in fact, now we are aware that the last year has changed things in fundamental ways. And then now with the spike in many of our cities, we are really concerned about the situation. As we grapple with all this, we also feel the need to take this work further into the altered future that is before us. And these conversations are a part of our ongoing work to develop a public health and a feminist policy framework on some of the issues that have been highlighted during the pandemic around the accountability of the state and also the role and responsibility of many international actors and pharmaceutical companies, especially around the broadest possible understanding of public health. With this little introduction, I invite Chayanika Shah, who's a scientist, a colleague, educationist, and a feminist, who is a part of this initiative to flag the key objectives and introduce the facilitators. And I welcome once again all of you and look forward to the conversations. Chayanika.
Thank you, Sarojini. I'm very happy to introduce the facilitators as well as to introduce these conversations. Because of the situation of COVID, we find that many of our demands and work over the last many years seems to be at a crossroads now. All inequalities in society that we could have seen are blown right open before us through this period of the last 1 year. The state seems to be getting more and more authoritarian, more and more difficult to deal with. And at the same time, we realize that without the state, actually, there's no way in which we can fight these kinds of pandemics. And in these times, then, to find a way forward. Now that we realize it's a year, the last year was spent a lot in trying to deal with the new situation, to deal with the disease itself and understand where we are going. But as we see, the future seems to be something where we have to live with this for a long time. We need to find paths with all of this happening around us at the same time. And one of the things that we thought of to understand this is to look backwards. To look backwards to past moments in history when similar things have happened. To understand what paths were chosen, how they were chosen, what were the things that worked then, what were the things that did not work. And maybe use that hindsight to create a foresight now. So that's one of the reasons why we decided to have a set of series of conversations on the histories of pandemics. And I was listening to Chinmay Tumbe the other day, and he said that when the pandemic began and everybody here in India was talking that the Indian population does not suffer from a pandemic because we are beyond such kinds of illnesses. And he went and looked back, and the city that I'm living in has been in a constant lockdown for the last year and more, and does not seem to be getting out of it in the next few months at least, is getting into a worse situation. And the city will just face this over and above again. So I really think that what we'll hear today is incidents of the past that have influenced the trajectories that we've taken. Maybe some of them helped us, maybe some of them did not help us, but we're really trying to understand these to see how we go ahead from here. With this, I introduce the two facilitators for today. Aditya Bharadwaj, who is a professor of anthropology and sociology at the Graduate Institute of International and Development Studies, Geneva. He completed his doctoral research at the University of Bristol and thereafter pursued his postdoctoral fellowship from Cardiff University, United Kingdom. His research is focused on biomedicine and biotechnologies, especially on the rapid spread of assisted reproductive technologies and stem cell biotechnologies across the globe. And in this context, we've met him through many summer conversations, and he's been a compatriot all along. He has authored and co-authored several peer-reviewed journal articles and book chapters. He co-authored Risky Relations, Family Kinship and the New Genetics, and is the lead author of the research monograph, Local Cells, Global Science, The Proliferation of Stem Cell Technologies in India. Welcome, Aditya, and lovely to see you here. The second facilitator for today is Rama Baru, also a long-time known feminist and person that we've worked with. She's a professor at the Center for Social Medicine and Community Health at the Jawaharlal Nehru University, Delhi. Also an honorary professor at the India Studies Center, Central China Normal University, Wuhan, China. Her primary areas of research comprise health policy, commercialization of medical care, comparative health systems, and health inequalities. She has authored and co-authored several peer-reviewed publications, book chapters, and books. Her most recent work is a book titled Commercialization of Medical Care in China, Changing Landscapes with Madhurima Nandi. She is currently a member of the Ethics Committee of the All India Institute of Medical Sciences in New Delhi. So welcome, Rama, and I hand over to Aditya and Rama to take this conversation forward.
It's a great pleasure and a privilege to be introducing the first speaker today. I'm speaking from a position of a bit of a fandom here. Thanks to his amazing writing, 2020 became that much more bearable and exciting and interesting to some extent. Prashant Kidambi is a historian and received his MA and MPhil from the Center for Historical Studies at Jawaharlal Nehru University and proceeded to do a DPhil from Oxford University. As you know, some of you may know, he's an associate professor at the University of Leicester, and he's the author of two fabulous books, which I really urge everybody to look at if they haven't already done so. The first book, rather fascinatingly, is titled Cricket Country, an Indian Odyssey in the Age of Empire, to 2019 Oxford University Press. Actually, I haven't managed to get my hands on this one, but I'm really rather looking forward to reading this book. And of course, my personal favorite from 2020, actually, I should say is the highlight of 2020 for me, The Making of an Indian Metropolis, Colonial Governance and Public Culture in Bombay. And it's fascinating a look at this really interesting period from around 1890 through to the 1920s. And I'm sure Prashant will be talking us through some of those elements today. His main research focus lies on the intersections of British imperialism and the history of modern South Asia, and with a concrete focus on making South Asian cities, amplifying South Asian cities and examining both local and global inflections that go into creating the urban cultures in South Asia. So without further ado, I'll step out of your way and hand you over to Prashant Kidambi, which I'm very confident is going to be a very fascinating journey through pandemics of past and in some sense connected to the present. Over to you, Prashant.
Thank you so much for those very kind words, Aditya. I'm so delighted to hear that my writing was of some use in this very troubled time. Of course, I should also thank the organizers, Sarojini and the entire team at Sama, for inviting me. It's a great pleasure and privilege to be joining you all. And I want to start by taking up what you mentioned in your own introduction, which is the contemporary moment and the urgency of this moment, which forces us to rethink not only our present, but connect it up and make sense of it in the light of what we've experienced in the past. It's one of the curious aspects of pandemics historically, certainly in South Asia, but I think the argument can be extended elsewhere, that even though they take a devastating toll when they occur, they seem to leave fewer traces in historical memory than other kinds of catastrophes. I think perhaps the exception to this might be the Black Death in your plague as Black Death. But by and large, if you think of India, for example, who today even remembers that the plague killed at the start of the 20th century, killed over 12 million people at a conservative estimate? Who remembers indeed the vast death toll of the influenza pandemic in 1918, 1919? I mean, India was very badly affected, but we hardly hear of this in popular memory. So it's very interesting that when pandemics occur, they seem to loom large over our lives. They overturn it in fundamental ways. But as time goes on, these events seem to recede from memory, and I can see that even happening with COVID. In 3 or 4 years' time, when we've acquired herd immunity, when we've got the vaccines, when we've got the protocols, and people are more robustly sort of able to deal with the disease, I think we may well find that this moment may well recede in memory. So I think it's very important to think about to recover those pasts, because as Chayanika said, there's a lot to learn from the past. At the same time, I'm also not one of those who believes that the past and the present are easily comparable. One cannot also forget the otherness of the past. So for the historian thinking about the relationship between the present and the past, the challenge is always, how do you make things comparable without at the same time losing the strangeness or the specificity of what happened in the past? And that is essentially the starting point for my own talk today. I mean, it's very clear that there's a new interest in the history of previous pandemics. I mean, Chayanika, you mentioned some Chinmay's work, and there are others. And I've been amazed at the number of invitations I've had to talk about this particular my work on the plague. And what's interesting here is that for a long time, this is actually, the work was known amongst a few urban historians, but there was no relevance, it seemed, for that work. And yet suddenly, because of the pandemic, people are looking for previous historical examples to try and make sense of it. And so there's this new interest in the history of previous such occurrences. And the resonances are very clear with our own contemporary moment. We've indeed seen very explicit parallels being drawn. A number of fairly uncontroversial conclusions have been drawn by comparing the coronavirus pandemic today to previous pandemics. We know, for example, that governing authorities often fail to spot the coming of pandemics. Once identified, panics and rumors tend to abound. As they unfold in time, they brutally expose the underlying socio-economic and political inequities and fissures within the societies in which they occur. They reshape state-society relations, they affect families and individuals, and they introduce a pervasive sense of fear and foreboding. All this and more we know because of the rich literature on the history of pandemics. And some of this will also appear in my talk today on the plague in colonial Bombay, because this was a cataclysmic event in the history of the city. Officially, it was acknowledged in September 1896, and thereafter it became a fearsome killer that took over 10 million or 12 million lives. The numbers are rough estimates over the following 2 decades. And in Bombay, the disease was at its most fearsome in the years between 1897 and 1907. So it was for 1 full decade, the plague loomed large over Bombay's history. And remarkably, not much had been done. When I started my research, there had been work on the plague, but the relationship between the pandemic and urban society had been sort of, it had stayed in the background largely. And that was what I was trying to recover when I wrote my own book. And the plague, of course, disrupted lives and livelihoods and devastated families and communities, much as is happening today. Now, what I want to do today is to think about the pandemic as event. That is, what makes a pandemic a historical event? And to do that, I'm going to talk about the first 2 years of the plague pandemic in Bombay. What I want to do essentially is to reflect on the status of the plague as a fundamental rupture in the fabric of everyday life, which disrupted the recursive patterns of social life. And I think looking at pandemics as events can give us a handle on this question of the compatibility of pandemics. So this is the approach that I'm going to take today. And I want to focus on the first 2 years of the plague as it unfolds in Bombay. This is the period between 1896 and 1898 or 1899. Because it's in these 2 years that we can speak of the plague as an event in the life of the city. It marked a clear moment of rupture when the specter of death loomed large over the collective life of individuals and communities. And thereafter, after those first 2 years, the plague loses some of the sense of some of its eventness, as it were. That is to say, it became an endemic disease in the city. It recurred every year. And curiously, even though the panic caused by the epidemic was at its most intense in the period between 1896 and 1899, it was the plague itself, in terms of its virulence, in terms of the mortality rates, was really took off after that period. That is, between 1900 and 1910, the plague was even more virulent and killed far more people. But the panic itself and the sense that this was an event, that was really at its most intense in the first 2 years of this period. So that is when plague has this, has its status as a remarkable occurrence which disrupts the structures of everyday life. So there are some parallels there that we can think about, but I'll postpone that, parallels of the present, that is, but I'll postpone that for the moment. So what essentially happens is that after 1899, the plague loses its status as an event. It becomes a part of what became the new normal in Bombay. Now, to explore the status of the plague as an event, I'll proceed in 3 moves. An event, as I said, is a rupture with what's gone before from the structures of everyday life that underpin life and normal life in the city. So my first move is to identify briefly the pre-existing urban context in Bombay as the plague was identified. Next, I'll focus in the second part, I'll focus on the moment of the rupture itself. And what I want to ask there is, in what ways and to what extent did the plague in fact mark a break with what had gone before? And to answer these questions, I'll explore different aspects of urban life that were touched by the plague. So analytically, I'll try to take in very quickly the urban economy, urban governance, and civic culture. And then finally, zooming back from the event, in the third part, I want to reflect on how the plague lost its status as an event. That is to say, how the plague became the new normal, how the structural transformations that it effected became embedded in urban governance and public culture in the city. And perhaps by the end of the lecture, the parallels and resonances between that moment and our own contemporary moment will become clearer. And we could perhaps reflect on that in the question and answer session that follows. So let me just begin by providing you with a very quick historical snapshot of Bombay prior to the plague, on the eve of the plague. And there's been a lot of talk about COVID as a consequence of the globalized world we live in. Something similar could be said about the occurrence of the plague in the context of Bombay's own evolution as a highly globalized port city. Oceanic trade had been the basis of Bombay's commercial prosperity for well over a century. It began with the trade in raw cotton in the late 18th century, followed by the trade in opium in the early 19th century. And together, those two commodities fueled Bombay's growth as a commercial town. And of course, they also laid the ground for Bombay's insertion into the capitalist world economy under colonial aegis. the port town's growth was shaped very much by its connections with the Far East and Europe. Now, what's very interesting, of course, is that in Bombay, Indian capitalists played a very crucial role in the growth of the port. And we have very famous commercial partnerships between Europeans and Indian mercantile groups, most notably the Parsis, but there were other communities too, and other individual businessmen, especially focusing on the trade with China. Now, the tightening webs of global commerce that made possible Bombay's prosperity in the mid-19th century also produced the first major crisis for the city. And this had to do with the American Civil War, whose commencement in 1861 triggered the infamous share mania in Bombay, which and largely because the supplies of cotton from the American South to Europe ceased. Bombay mercantile groups moved in to fill the gap. There was a huge boom. And of course, much of the profits were fueled into all kinds of speculative ventures that created this share mania, as it was called. And of course, when the Civil War ended, the whole edifice came crashing down spectacularly. But of course, Bombay recovered after that. 1869 saw the opening of the Suez Canal, which has, of course, been much in the news. And Bombay is one of the beneficiaries of this reduced traveling time between Europe and India. And of course, this is the period from in the last quarter of the 19th century that Bombay becomes a major industrial city. The first cotton mills had been established in the 1850s, but it's really from the 1870s onwards that the cotton mill industry in Bombay really takes off. And of course, that draws a large laboring population to the city. So really, Bombay by the mid-1890s is a boom town. And of course, buoyed by this very dynamic intersection of commercial, financial, and industrial capitalism, you get a very highly multi-ethnic, plural urban culture. I won't use the word cosmopolitan because there are some problems with that term, but this is a very plural city with many different religions and communities and languages, all learning to do business together and creating that very distinctive dynamism that is Bombay. But of course, inevitably, there was the other side to urban development and Bombay's boom, which was the stark inequalities within the city itself. Even as Bombay's business expands and even as Bombay becomes a highly prosperous commercial town, it also, the arrival of migrants, large numbers of migrants in the city happens in a context where there's very little social provision of housing. These workers are crowded together in what came to be known later on as hovels and slums and so on. There was huge overcrowding, and the civic infrastructure of the city did not move with the growth of the city itself as an industrial metropolis. In fact, Bombay may have grown as an industrial city and an industrial metropolis, but its civic infrastructure was very pre-industrial in nature. And I've documented some of this in my book, this contrast between the commercial success and its becoming an industrial metropolis and the underbelly, which is, as we know from cities elsewhere, one of stark, glaring, unequal social relations and economic relations and poverty and so on. And as the work of Ira Klein demonstrated many years ago, Bombay between 1870 and 1914 had extraordinarily high death rates, and these were largely and disproportionately affected the urban poor. It was the urban poor who were basically the biggest victims of the city's commercial prosperity and its growing inequality. But none of this really induced any changes in the nature of civic policies. This was a city whose creaky sanitary infrastructure was not overhauled. Colonial officialdom was very phlegmatic in its view of the city's high death rates. It was seen as par for course in a tropical city. There was, of course, a newly designed municipal corporation following the Municipal Act of 1888, which increased the elected element. This was a body largely dominated by Indian mercantile and propertied elites, drawn from different communities, and of course controlled by the British in terms of its executive structure. And these local propertied interests tended to cavil at the prospect of any investment in the city's civic infrastructure. Even such sanitary measures that were introduced from time to time encountered the resistance of local communities. And governance, for the most part, was carried out through the leaders of mohallas and neighborhoods. There was often great unrest over the implementation of municipal regulations and so on. This should not be seen as a sign of a sort of backward cultural attitudes. It was more a question of class interests, and largely had to do with the fact that local property elites were being asked to pay for these any changes or improvements to the civic infrastructure, and they resented having to do so when the changes came from these colonial authorities, who were obviously not keen to invest in the civic infrastructure themselves. So this then is the backdrop against which the plague unfolds in Bombay. Now, clearly, the eventness of some events makes itself, appears even before the event itself has occurred. If you think of political revolutions, or you think of the uprising of 1857 and so on, there were already signs from before that something like this was going to happen. That kind of impending mood of danger and doom, that did not really manifest itself prior to the identification of the plague in Bombay. The warning signals had been present, though, because through the first weeks of the monsoon of 1896, Indian medical practitioners in the areas close to the docks had begun to come across cases of fever accompanied by glandular swellings. But these were taken to be examples of more familiar kinds of glandular fever previously present in the city. So it was not until the 23rd of September 1896 that a local East Indian doctor, Dr. Acaccio Gabriel Vigas, he was a medical practitioner, local noteworthy in municipal politics. He declared in the BMC that bubonic plague had broken out in the city. But even in the days following this startling announcement, the municipal medical establishment in Bombay was loath to accept that this was indeed the plague, and thereby granted the status of a major event. While they conceded that the cases of this new disease was indeed suspicious, they used a variety of vague terms. They called it bubonic fever, fever plague. It was only in October 1896 that the colonial government finally confirmed that the disease in Bombay was indeed bubonic plague. And no doubt, the global politics of the time had forced their hand, because the announcement from Bombay led to the swift imposition of travel restrictions across Southeast Asia, the Persian Gulf, East Africa, to ships arriving from Bombay. European powers, alerted to the outbreak in Bombay, began to clamor for measures to prevent the import of plague into their own countries. And faced with the prospect of a collapse in Bombay's trade and driven by deep-seated anxieties about the disease itself, this was after all, the Black Death, and it loomed large in the European imagination, certainly. Colonial authorities unleashed an extraordinarily fierce response to the disease in their midst. Now, the relevant point here is that though the plague became designated as an event by this announcement, this eventness, the fact that it was designated as an event, was not because of its of the virulence of the plague at the outset, or even the rising numbers of death, but because of imperial and geopolitical factors that forced colonial authorities in Bombay to recognize that this was a crisis with potentially significant ramifications for the future of the city. Now, one problem that the colonial authorities had in confronting the disease was that they did not know its precise mode of transmission. There was considerable uncertainty over whether plague was an airborne disease that was passed on from person to person as a contagion, or whether it was a product of localized conditions of filth and miasmas. Now, in the scholarship on the plague in India, colonial India, the earlier tradition, writers going back to Arnold and others, the earlier body of scholarship tended to emphasize the contagionist underpinnings of colonial plague policy. And they focused on all the steps taken by the colonial government to identify and isolate suspects, the way in which infected patients were kept in hospital and their contacts localized in segregation camps. So quarantines, hospitalizations, segregation measures, these were the focus of the research. And Arnold famously dubbed this as the colonial state's assault on the body of the colonized. My own work has tried to shift the focus, and I'll come to that in just a moment. What we need to sort of think about in relation to this is how contagionist policy was one dimension of what was going on. for many of the colonial authorities in Bombay, the plague was actually a disease caused by filth and poverty. They believed that the plague was only lightly contagious or infectious, that it was very much a product of localized conditions of localized insanitary conditions. And this drew on a long tradition whereby disease in Bombay was explained in terms of local factors. This was a conventional explanatory mode. Of course, now those medical practitioners who said the plague was caused by miasmas and so on, they had to sort of reconcile it with the fact that a bacillus or a microbe was discovered as the cause of the plague. And what actually happens in practice is that local authorities in Bombay proceed on the basis of what I've called, drawing on some scholarship about plagues and epidemic diseases in the European context, what one might call contingent contagionism, which is that plague was seen to be associated with a microbe, but this microbe itself was seen to be a product of conditions of filth and insanitary conditions. And it's not hard to see why this localist theory was so persuasive in the context of the plague in Bombay, because there was the suspicions that people had about germ theory, about microbial theory. This was a time when the dominance of sort of contagionist theory based on on establishing the presence of microbes through the microscope and so on. It was still a very contested field. So there were many who were suspicious about the new microbial theories. Secondly, the localist theory supplied a very plausible account of the disease in the context of very considerable uncertainty. And finally, it also supplied an explanation, a plausible explanation for very observable features of the disease. The fact that the earliest cases had been found close to the docks and the warehouses in the eastern and central parts of the city. So the big consequence of this is not only were policies followed on the basis of the contagionist understandings, that is hospitalization, segregation, but you also had a very huge and systematic assault on the buildings in Bombay. And in my book and in other papers, I've documented the extraordinary scale on which this assault on the neighborhoods, especially the neighborhoods of the poor, was carried out. Much of it was on the basis of the use of force. You had the creation of the Epidemic Diseases Act in February 1897. Local authorities could enter buildings, they could declare them unfit for human habitation, they could lime wash them, they could take off their roofs, they could burn them. So, and this is indeed the act that was invoked when the corona pandemic broke out. So the Epidemic Diseases Act, introduced in February 1897, was a massive sort of instrument of this state intrusion into not only the bodies of the poor, but also into the homes of the poor. And this has long-term consequences. In 1898, you have the creation of the Bombay Improvement Trust, which is explicitly set up to, as a civic agency, to deal with the problems, the sanitary problems created by the plague. And indeed, it is the first such civic agency in the whole of Asia. And the model, the Improvement Trust model, was to prove hugely influential in the following 3 decades as far as the colonial approach to urban development goes. So in this regard, the plague was a rupture in the existing structure. Above all, it forced the colonial authorities to eschew their salutary neglect of civic infrastructure and invest time and resources in the remaking of the city. The manner in which the colonial authorities dealt with the plague pandemic also represents a rupture in the practices of colonial statecraft. Colonial authorities were forced to jettison their existing strictures about not intervening in the lives of local communities. The notion of indirect control, which had dominated colonial governance until this point, gave way to a very brutally intrusive colonial regime. At first, this intrusion was spearheaded by the local Bombay Municipal Corporation, but as they faced unrest over the plague measures, and given that many of them were local representatives, they found themselves sort of hesitant in taking really firm executive action. And that is why you get the appointment of a new military committee headed by, in the spring of 1897, it's headed by Major General William Gattaker, who's one of the big military heroes of the time, who was tasked with spearheading the anti-plague offensive. And this committee, sort of basically engaged soldiers in carrying out house-to-house searches. They drew on Indian volunteers, but the focus was very much on the forcible stamping out of the plague using, the colonial army, working in tandem with local volunteers. Now, as it happens, the first wave of the pandemic began to wane just about the time that Gattaker began his counteroffensive. And so the soldier was very quick to claim credit for this success. But barely had, they stopped congratulating themselves that the disease returned with a vengeance in the winter of 1897. And once again, a plague committee was forced to deal with this renewed outbreak. The second wave of infections was even higher than the first wave. And again, the old strategies of directly intervening in the neighborhoods of the poor was recommenced. The result, of course, was renewed hostility between rulers and ruled, culminating in the riot, the major riot of March 1898. This was very notable for the assault on Europeans in the city. It started when a plague search party tried to forcibly remove a young girl from the Julaha neighborhood, the neighborhood of weavers, in which her case had been discovered. The use of force led to a standoff. There was firing, and then, of course, a riot. And in this riot, Europeans were targeted explicitly for the first time. So we see then a rupture in colonial statecraft and in the breakdown of carefully calibrated strategies of rule. In the interest of time, I'm not going to get into the questions of economy and civil society, but I can answer that, or can talk about that in the question and answer. I want to end then by looking at the significant ways in which the plague was a moment of profound rupture in the history of Bombay, by sort of pulling together some of what I've already said. The plague clearly fits the bill for what can be legitimately recognized as a major historical event. In all the ways that I've outlined, it marked a major departure from the practices of colonial governance and indeed the way in which civil society functioned in the city until that point in time. But gradually, as the plague became a recurring feature of Bombay's life, by the end of the 1890s, the pandemic lost its status as an event. It now became a regular, everyday occurrence. It's something that became a part of what one might call the new normal, using the terminology we've become familiar with. It became an endemic disease which appeared year after year in a recognizable pattern. So every year, there would be a gradual build-up over the winter months. The disease would peak in January, February. The highest death rates would occur then. Then towards the beginning of sort of spring, the rate of death would decline. By the summer, they would be at a low ebb, and then the whole cycle would start again. In the autumn of the later in the year, as it were. And this became the new normal for Bombay's population. They got used to living with the disease. If you look at accounts of people, memoirs and so on, they'll talk about how every year in the winter months, they would leave Bombay. The poorer people would go and settle in camps outside the city. The rich would go away to hill stations and so on. And then they would all return in the spring. Gradually, too, the panic surrounding the disease began to subside. One reason, as I said, is because once the disease began to recur year after year, people kind of found ways of dealing with it, and some of that novelty, the fear of that initial appearance of the disease faded away. But it also was because it became quickly apparent that the plague was not killing Europeans in anywhere the numbers that they had feared at the start of the outbreak. Because remember, one of the reasons that the colonial authorities drove forward this very intrusive policy was because of their own fears of what plague had done to European society over the centuries. So that was the fear that drove the colonial state's own panic-stricken response to the disease. Once it became clear that the plague was not really killing that many Europeans, in fact, most of the death rate, most of the deaths were amongst the Indian communities, then European, there was more of a sense that, the Europeans could sort of breathe a sigh of relief and take the precautions, but, they didn't have to kind of, the panic that was there in the early years was no longer there. And of course, the political resistance of the local population to colonial plague policies also triggered a reappraisal of the draconian measures that the government had pursued from the very outset. So as a consequence, by 1900, there was an easing off of the restrictions and a relaxation in the plague policies. But if plague lost its status as an event, I still believe that its historical significance for Bombay was to endured well after the panic surrounding the plague had subsided. In that sense, it was very clearly a turning point. So I'll just end by illustrating this very quickly. So if you take the realm of urban governance, the direct intrusion of the state into the urban neighborhoods was institutionalized. So two examples of this, I've already talked about the Bombay Improvement Trust, which is one example, but there were also significant changes to the Bombay City Police. The new City Police Act was introduced in 1902. It's still the basis on which the post-colonial police functions. All the provisions are really the provisions of this City Police Act of 1902. And this involved a significant degree of state intervention in the remaking of Bombay's urban spaces and neighborhoods. So you find the plague is a turning point in that it inaugurates a new state interventionism in the use of space, in the regulation of space, in the policing of space. And this, alongside the Bombay Improvement Trust, means that the state becomes a much more pervasive presence in the lives of Bombay citizens than had been the case before 1896. You also see, with regard to the realm of civil society, the growth of civic efforts in pursuit of what one might call, following Ruth Rogalski, a hygienic modernity. You have the creation of institutions like the Bombay Sanitary Association, which was founded in 1904. You have the Social Service League, which was formed in 1911. And what you find here is that everyday discourses emerge about the importance of sanitary awareness, hygiene, bodily discipline, training the body to withstand disease. The class dimension to these discourses and practices also has its, there's another side to it, which is essentially the stigmatization of the poor and the slums and so on. So you get a middle class consciousness about the poor around questions of hygiene that becomes quite apparent after the plague years. And in terms of the civil society actions itself, this is the time when you see a lot of these initiatives focused on sanitary awareness. So that is another crucial way in which the plague is a key turning point. So let me just end by saying that traditionally, the historiography on the plague in colonial Bombay has tended to see it as a short-lived event. And there is something to that, in that the panic and the upheaval that was caused in the first 2 years is what gave the plague its specific sort of force in urban life in the late 1890s. And it was a panic, as I said, that seized rulers and the ruled alike for that brief moment of time. But I think there's a danger in just focusing on the plague purely in terms of those the immediate impact, is to miss out some of the longer term consequences of the event. And I think a real crucial test for an enduring historical event is whether it can transform the recursive patterns of life, that is, the established structures in any fundamental way. And I've tried to argue that, in viewed thus, the plague was also an event in that second sense, that it did constitute a very fundamental rupture in terms of the structures of governance and the structures of civil society. And so the burden of my argument today has been to suggest that while panic and, there was certainly panic in the first 2 years, and the plague was certainly an event in terms of being a rupture in terms of the immediacy of what happened between 1896 and 1898, it is equally an event in the most substantial sense of transforming in very consequential ways the multiple structures of urban life in Bombay in the early 20th century. I think I'll just stop there.
Thank you very much, Prashant, for the absolutely fascinating talk. We have a few questions here, but let me just flag up by pointing out something very peculiar that I've been following in international media vis-a-vis the Indian experience of the current unfolding COVID-19 pandemic. And I really love your perspective and take on that. And also that speaks to some of the questions that have come in, and I will sort of try and braid them in. into this sort of a larger point that I would love your reflection on. So one of the things that I'm seeing in a lot of the international press is this sort of, it went through these several waves. There was the doom and gloom scenario in India, 1.3 billion people, and this is going to be a major havoc, and we're going to see unprecedented numbers affected and so on and so forth, to the point where a certain more calmer, more reasoned sort of reflection began to look at the actual disease burden and the recovery rates, however flawed the data. There was a grudging acceptance that actually it wasn't as disastrous as they had first imagined it to be. Mm-hmm. And one of the explanations that emerged, which really speaks to your orthodox contagionist doctrine thesis, or what you beautifully conceptualize as contingent contagionism in the book, one of the things that they zeroed in on was the sanitary disorder itself. And so one of the explanations that the public health mavens began to pontificate on was, thanks to the squalor and the filth and the sanitary disorder, that there is a pre-existing immunity of the poor, which is able to ward off the COVID-19 affliction and infliction in ways that makes the Western populations more vulnerable. Right. So suddenly there is a recouching and a reframing of the sanitary disorder in its sort of very orientalizing and essentializing mode, which sees the poverty of the poor and their unsanitary existence as one of the explanations why India hasn't done as badly as it was first anticipated. So I thought, there was a certain very interesting reversal happening here of this sanitary disorder, yes. and that how do we begin to make sense of this partial explanation that people seem to be gravitating towards? And of course, a lot remains to be seen how in the second wave and the subsequent third wave, how is India going to do? That's an open question, because as numbers rise, we are in the thick of now the again unknown. And if anything, the current indication suggests that it's going to be a little worse than what it was in 2020. So in that respect, there's also a question sort of touching on this theme by Geeta Sen, who asks, did the new normalization of the plague arise from it becoming a disease more likely to hit poor as the wealthy and the middle classes learned how to avoid it? And so what is happening with COVID is that the disease burden is disproportionately amongst the wealthy. And one of the things that one hears and one trying to glean from the media accounts is that thanks to their air-conditioned, sanitized lifestyle, there is not enough freely circulating air, and that therefore the disease burden amongst the rich and the well-off is that much higher. And thanks to the free flow of air in these often very tightly packed slums, one sees a certain order in the sanitary disorder itself. Yeah. So I would love your thoughts on that. And then I'll come to some of the other questions which sort of link up to this larger theme.
Yeah, no, that's a brilliant observation, and that reversal that you talk about, because obviously in the case of the plague, all those, the focus on the underlying sanitary conditions was meant to explain why the poor were more vulnerable to the disease. Whereas now, of course, you see it's the opposite, that somehow the poor in India over a century have been inured to disease because of the robustness they've acquired by illnesses and diseases and so on. I think the interesting thing here, of course, is that, when we look at scientific explanations, the idea, or medical explanations, the idea like medicine, like sport, is above politics and, social attitudes and so on, that it's somehow divorced from all of that. It just shows that how problematic that reading is, because clearly, all medical theories connect up with the underlying social structures or the social perceptions or social assumptions. It may well be that the most accomplished practitioners eschew that way of thinking, but we know that in popular discourse, these sorts of assumptions and connections are often made. There's a kind of assumption that assumes, that in the early 20th century, it assumed that the poor had to naturally be the bearers of contagion. They also had to be more vulnerable precisely because of the way in which the disease was linked to the underlying sort of sanitary conditions. And as I've said, the reason that the way people instinctively made sense of this new disease in the context of Bombay was that, oh, right, in Bombay, we've always had diseases, and these diseases always happen in these places, and they always happen because of these conditions, and the plague is no different. And well, you might have a germ, but that germ itself is a product of the filth. That's the reasoning, And so the idea that there could be something like a rat flea, that had been suggested, but it was not until the mid 1900s that theory actually establishes itself. So for the first 10 years, now, we actually end up telescoping historical time, and we see things teleologically. But just think of it, for 10 years, you had policies that didn't accept this and were based on a completely erroneous assumption. And I suspect something similar will also happen in the case of what's going on now, except, of course, that because the understanding of this theory, the explanation for this disease and its spread is different, people are looking for other social vectors, and it's so I think the larger question that this raises is the relationship between medical theories and their so-called scientific status that are somehow neutral and are objective and are sealed off from everything else, and the way in which in practice actually wider social assumptions inform these theories. And I think one can set up parallels to think about how one can compare and contrast the plague, for example, and the pandemic today. So yeah, I think this is a very interesting point, and I'd be actually interested in hearing what others have to say about this.
Sure. I mean, of course, there is a sort of a supplementary sort of point here, which says that Hispanics and African Americans have much higher COVID infection death rates than whites. The States. But that is, of course, true. But also the nature of poverty is very different.
I think I think one of the interesting things about plague, the COVID thing, though, is that it's moving and changing so rapidly that the theories are not being able to keep up, or even the assumptions are being wrong-footed constantly. So, we started by saying old people are more vulnerable. Now, suddenly from Brazil, you say actually lots of young people are dying, and then you said Indians are not the same. But suppose, you have a surge in the Indian context now. We may well be forced to revise some of our understandings. So what's very interesting is in any particular social context, I think what would be worth researching is what is the social reception of these theories? Why do some theories seem more plausible in some contexts than others, And how do we think about that comparatively? Yeah.
Media soundbite culture, that's what it's really capturing.
Yeah, so it would be really interesting to see,
so the graph of the media.
So it would be interesting to do a study of the reportage and the kind of explanations that become popular in any particular context. I mean, you also have particular contexts in which the scientific theory itself is refuted in toto. I mean, there are parts of the US where people still don't believe that you have COVID, that it's a figment of the. So it actually tells you that, this is a question about the relationship between medical knowledge and its social reception, I think. And contrary to what we think, medical practitioners are actually deeply implicated in those. They're not sealed off from it. I mean, medical practitioners in Bombay were drawing on very widely pervasive social assumptions of their class and their particular, the group they belong to in understanding and making sense of the reality.
True. So there are quite a few questions have come in. So I'll take a few perhaps, and I should be keeping track of time, but I'd be very grateful if somebody from somehow kept track of me. Not keeping track of time. We might get carried away because there's some really interesting questions here, which I think I should take.
Maybe a couple of them, Adi.
Yeah, I'll take a few, and then we'll try and save as many of these questions as we possibly can, and then perhaps we can continue the conversation even via email. So the next couple of questions that and I'm taking them in the order they appeared. So what public health structures were present in Bombay at the time? And for instance, was there a chief public health officer or some kind of a bureaucracy supporting such a officer? And the second question following on from that is that in Bombay, was there any suggestive evidence of airborne transmission of the plague, as well as was established in the Harbin or Manchuria in 1910? So was there anything similar to the, I'm not very aware of the Manchurian 1910 plague, but was there there was a sense, a knowledge of the airborne transmission available at the time. Then taking one more question, if you'd allow me, to see that, do you see parallels, differences between what happened in 1898 and what is happening now with the COVID-19 pandemic in terms of ruptures in governance, draconian measures, the state of exception, and the invoking of EDA and DMA?
With regard to the first question, yes, there was a health-related establishment in Bombay. Health was a municipal subject. You had the executive health officer in Bombay who used to report on the state of health, mortality rates, etc. So you did have that sort of infrastructure. You did have some hospitals too, though of course plague also spurs the creation of a lot of community hospitals. So that's the answer to your first question. One of the things that happens in as soon as plague is publicly announced, is you have the arrival of scientists from other places, and because plague had also happened in Hong Kong, so there was a lot of interest in trying to find out what was going on. They did look for evidence for airborne transmission. There was some sort of some who believed that it was in fact transmitted through through the air, and that is why you had the attempts to kind of lock people up in, take people away to hospital, put them in segregation camps away from other contacts and so on. But I can't recall offhand if they did actually have systematic studies of this, because the reports that I looked at were more diffuse in this regard. They talk in more general terms about the kind of policies. So the specific studies that might have been conducted, I'm afraid I don't really know that much about. I think the second question was more about the state of exception, and
so do you see any parallels, differences between what happened then and what's happening now in terms of measures and governance, draconian measures, and the state of exception?
Yeah, I think certainly you can see in terms of the legislative instruments, the fact that the Epidemic Diseases Act was invoked and so on. So that's one, and that act has been on the statute books pretty much unchanged since it was introduced in February 1897. So that's one area where you can kind of look for some parallels. One of the big differences, it seems to me, is that the colonial authorities were much more, their response was very authoritarian at the outset, and they were quite brutal in terms of pulling down, all these neighborhoods and so on. My own sense of the way the plague was conducted, the COVID operations were conducted in Bombay, certainly, in Mumbai, I think it seemed to me that the local authorities were much more responsive and sensitive to the flow of public opinion. Certainly, I didn't see the youth. Of course, the lockdown created all kinds of problems. But, in terms of forcible intrusion and so on, it seemed to me that was less prominent. Maybe it did happen on the ground, but my own sense was that certainly the BMC, when it came to a place like Dharavi, where there were all these fears that, that it would be, the plague would be, so the COVID would be completely rampant, seemed to have actually worked in quite an intelligent manner in working with local communities and local doctors and so on. Now, the colonial authorities also actually had an element of that at the start, in the first months, 1896, the winter of 1896. But because the plague cases kept increasing, and there was a real sense that the disease was getting out of hand, that's when you get the, the turn to a military committee and so on, the explicit use of force. But the municipal authorities were struggling because they were trying to be, less, they were trying to be a little more responsive to public opinion. So, for example, they issue a proclamation in October 1896 saying everybody who's identified with the disease will be taken to hospital. Then the property groups in the city kind of say, well, we are respectable people. Why should we go to hospital? We can be taken care of at home. And then they revised their that ruling and so on. So there was a kind of and they worked through local volunteers and so on. But because the thing got out of hand, then they take this turn to a very authoritarian sort of mode in 1897. So I suppose that's a second area, to kind of think of the extent to which there was some, that the state works through local agencies and works with local communities. And it seems to me that that in the case of COVID, certainly, we did see that, especially from what I've read of how it was done in Dharavi, which is why I think Dharavi was touted as a success, that they did manage to succeed. They had fewer people sort of not cooperating and so on. But it is very interesting that fundamentally, I think pandemics do become comparable because they put the onus on the state in some ways, and state responses to pandemics often have to take, there is at their heart, there is a very interventionist agenda, that you have to intervene to sort this thing out. Even the most laissez-faire state finds that a challenge. I mean, the British state, for example, has found it a challenge because its orientation, certainly led by the leadership, is to have a more laissez-faire attitude. But the hand had been forced. I mean, nobody looked more miserable than Boris Johnson when he had to announce a lockdown, because it was fundamentally against his instincts. But he realized that if he didn't do it, there was going to be hell to pay for it. So, and we've ended up with extraordinary levels of state intervention. So I do think at a very fundamental level, pandemics do pose challenges to state and do initiate a logic whereby a high degree of state interventionism becomes almost inevitable, to deal with it, because the state is the only agency which can kind of the only agency which constructs the pandemic as a coherent whole, because all of us experience these things in a much more fragmented way, right? The state is the only one which is able to exercise, construct this in a more totalizing way, because it has to pull together so many things. And I think that then means that there is a degree of comparability across pandemics, because you can just, and I think this is very standard, in sort of medical writings and the medical history work has often focused on this element, isn't it? What is the relationship between the nature of the government and the kind of state response, so as I'm thinking here, even of political ideologies, whether a laissez-faire oriented government will have the same attitude to the disease as a more interventionist minded, whether you can compare a China, say, with a country that doesn't have that kind of orientation to intervening in society. So I think that's something that allows one to do that kind of comparison. But thank you so much, Aditya, for your comments, and thank you all for your questions. I'm sorry we can't have more time to do that.
Yeah, I know, it's quite unfortunate. We really thought, but beyond 2 hours, many people would like to go back, and that's the reason.
Yes, no, of course.
Thanks a lot, and thanks, Adi. Shall we move on, Chayanika, to Rama?
Thank you. It gives me great pleasure to introduce the next speaker. Dr. Carlo Caduf is a reader in the Department of Global Health and Social Medicine at King's College London. He also serves as the Director of Postgraduate Research Studies and Chair of the Culture, Medicine and Power Research Group. Moreover, Dr. Carlo is affiliated to King's India Institute and is a visiting faculty at the Graduate Institute, Geneva. He received his doctorate in anthropology from the University of California at Berkeley. His research concerns include questions of global health and disease, science and technology, medicine, ethics, and morality. His first book, The Pandemic Perhaps, depicted how pandemic influenza became a global threat. Dr. Carlo has also received an Investigator Award from the Wellcome Trust in 2019 to examine the changing landscape of oncology in India over the course of next 5 years. Welcome, Carlo, and we look forward to listening to you.
Thank you so much, Rama, for this kind introduction. and thanks to the organizers at SAMA for the invitation to speak in this workshop. I would like to just start by sharing my screen. Let's see if this is working. So I wanted to start with the following question. Was the pandemic unprecedented and unexpected? And as we have heard from Prashant before, there have been many pandemics before. He was talking about the plague pandemic in Mumbai, but there have also been other pandemics, like the pandemic of influenza in 1957, which killed between 1 and 2 million people. There was another pandemic of influenza in 1968, which killed between 2 and 4 million people. And then we have pandemics or epidemics of TB, of malaria, of HIV, and so on, which continue to kill millions of people worldwide. every year. So, so we can't really say that pandemics or outbreaks of infectious diseases are unprecedented. And we can't even say that they're unexpected. And I just want to refer here to the H5N1 avian influenza virus, which some of you may remember was spreading around 2005 and was mainly infecting birds and chicken. But at the time in 2005, many experts were saying that this virus might adapt to humans and then might cause a global pandemic and create a catastrophic event. So here you can see a cover from the Time magazine. This was published in 2005, the avian flu death threat. So there was a huge discussion, not only among public health professionals and infectious disease experts, but also in newspapers around the question of when the next pandemic might happen and what the most likely cause of that pandemic might be. At the time, everyone was focusing on the H5N1 avian influenza virus, but this virus, as we know, never actually caused a pandemic. Here is just one second. Just a report from the US Institute of Medicine, which was published in 2005, and it stated that most infectious disease experts believe that the world stands on the verge of an influenza pandemic. Pointing to growing signs of danger, experts presented pandemic influenza as an inevitable event and suggested that it was important to raise the profile of the flu, thereby captivating the public by the buck and making the possibility of a pandemic a priority for the population. So the flu, they thought, was more than just a seasonal nuisance. It was a threat to the security and prosperity of the nation, and it deserved more respect. It was important to keep up a steady drumbeat to motivate action, mobilize resources, and create more interest in preparedness nationally and internationally. The result of this in the United States was a call to change, which offered a combination of pessimism, the pandemic was unavoidable, and reluctant optimism, disaster could be mitigated if the right steps were taken. So as you can see, there was a lot of action and a lot of attention that was given to the possibility of a catastrophic pandemic in the early 2000s. So even scholars like Mike Davis wrote books, this one with a very dramatic title, The Monster at Our Door, The Global Threat of Avian Flu. Public health organizations like the Trust for America's Health published reports. Here one that was highlighting the fact that flu can take many different forms. It can be a seasonal epidemic, but then it can also appear as a pandemic and kill much more people. So one needs to pay attention to the influenza. As Prashant already mentioned, there was a big pandemic of 1918, which killed up to 50 million people. And so in the 2000s, experts and public health professionals were constantly remembering the catastrophic pandemic of 1918 and constantly pointing out that an event such as the pandemic of 1918 might happen again in the future, and that it was important to prepare for such an event. So at the time, the world or the US or people were in a strange space, which is a space in between the day after the pandemic of 1918, but that day after the pandemic of 1918 was also the day before. So the world was imagined as a world that was waiting for the next event to happen. Public health professionals responded to the threat of pandemic influenza by investing in preparedness. So a new idea emerged, the idea of preparing for a pandemic influenza, and a lot of resources went into preparing countries for pandemic influenza. And this took different shapes in different countries. This is a flyer from the public health department in the US, and the right prescription is preparedness. But there was also a number of reports that were published. Here is the National Strategy for Pandemic Influenza, published by the Homeland Security Council in November 2005. But even the WHO published a global influenza preparedness plan in order to prepare the world for a pandemic. So as you can see, experts expected a pandemic, and so we can't say today that it was an unexpected event, because a lot of effort and a lot of thinking and a lot of resources went into preparing for something like the COVID-19 pandemic that we are witnessing today. This is a pandemic influenza plan that was published by the New York State Department of Health. So as you can see, on multiple levels, officials began to think about how to prepare communities, states, even whole countries for a pandemic. One part of this preparedness, and this is important to keep in mind, especially in relationship to the United States, was the idea that everyone needs to prepare. So from the very beginning, government officials encouraged citizens to prepare for a pandemic. So there was even a National Preparedness Month. Every September, it was declared in the United States. And the key message was always, you need to prepare, you need to make an emergency plan, you need to know what to do when an influenza pandemic happens, because the state can only do so much, and a lot needs to be done by citizens themselves. So citizens, in a sense, were made responsible for their own survival. Now, part of this effort in preparing for a catastrophic pandemic was also an effort to measuring preparedness. And here I want to discuss just quickly the Global Health Security Index that was published in 2019. And it's a very interesting report, and you'll see why. So this was an assessment of preparedness. It was based at the Johns Hopkins University, and it was funded by the Bill and Melinda Gates Foundation and other funders. A project team worked with 21 experts from 13 countries on this report. They developed a framework with 140 questions. There were 34 indicators and 85 sub-indicators to assess a country's capability to prevent and mitigate epidemics and pandemics. And they looked at a whole range of different areas. The first one was prevention. Then they looked at detection and reporting. They looked at rapid response. They looked at health system questions. They looked at compliance with international norms, and they looked at risk environment. So as you can see here, the focus was quite broad, and experts tried to measure preparedness and then also to rank countries according to their state of preparedness. And they came up with an overall score, a preparedness ranking, where all countries in the entire world were ranked according to their according to their preparedness efforts. And as you can see here, the most prepared country for a catastrophic pandemic, according to these experts, was the United States. It was given the first rank, and the second rank went to the United Kingdom. And then you can see some other countries like Sweden, Denmark, France, South Korea, Germany, and so on. So according to these experts and this report, which was published in 2019, the United States and the UK were the most prepared countries in the world. Now, of course, today we see headlines like this: Britain's COVID daily death toll is one of the worst in the world. What went wrong? And indeed, when we compare the ranking, the preparedness ranking, with the numbers of people who have been infected and people who died from COVID-19, we see that the United States is both seen as the most prepared country, but at the same time, it also has the most number of deaths and numbers of infected people. So that creates a slight cognitive dissonance. And it raises an interesting question if we conclude that the most prepared states have also some of the worst death rates. So what does that mean? And how can we explain this? Is preparedness maybe dangerous for health? Now let's look at preparedness itself and try to understand what preparedness as such might be. And here I want to start with Andrew Lakoff, a sociologist who has written around and about preparedness. And one of the things that he said is in this article from 2008 is that over the past 3 decades, a new way of thinking about and acting on the threat of infectious disease has emerged. For public health and national security officials, the problem of infectious disease is no longer only one of prevention, but also, and perhaps even more, one of preparedness. So he identified a shift from prevention to preparedness. And by preparedness, he means the following. First of all, he says preparedness is a new normative rationality that is defined by, first of all, a distinct understanding of the threat. So according to preparedness, the threat is generic. So preparedness is preparedness for generic biothreats, not just for specific diseases, but for generic infectious disease events. The second important characteristic of this normative rationality is that the target is the public health infrastructure. The form of knowledge at the heart of this rationality is what he calls imaginative enactment. And the last and maybe most important characteristic is the technique of intervention, which according to Lakoff is capacity building. Now, in the remainder of this presentation, I want to suggest a slightly different understanding of preparedness, and I want to situate preparedness within a different context. And what we will see is that what Lakoff calls capacity building is actually the least developed element of preparedness. So what I want to suggest is that we think preparedness in relationship to what Lee Jones and Shahar Hameiri have called the regulatory state. So what is the regulatory state? The regulatory state is part of a wider shift towards neoliberalism, where government has been largely replaced by governance, and whereby resources, authority, and responsibility are dispersed to diverse public and private actors, while central state managers retreat to a regulatory role using negative coordination to steer these actors in a broadly favored directions. So the key, so this is what they mean by the regulatory state. And the important thing is that they point out that the regulatory state has a number of key pathologies. And these key pathologies are, first of all, a deliberate reduction of popular expectations of public authority. So the public expectations are being managed in the sense that public is encouraged to expect less from the government. The second key pathology is that responsibility is being outsourced to technocratic, private, and quasi-autonomous actors. The third key pathology is that there's a weakening line of control and accountability. And the fourth key pathology is that there is a hollowing out of state capacities and authority to the benefit of frequently inept large-scale operations. The result of all of this is a systematic inability to address basic social problems. So this is what they mean by the regulatory state, and these are the key pathologies or the key problems at the heart of that form of the state. Now let's think about preparedness in relationship to the regulatory state. So what we can say is that the failure of the pandemic response in countries such as the US and the UK reveals the inherent pathologies of the regulatory state. What it reveals is a continuous decline of effective state capacities, outsourcing of key state functions to the private sector, a diffusion of responsibility in a fragmented system, and a reliance on improvised emergency measures. So preparedness in the regulatory state takes a very distinct shape. What preparedness means in the regulatory state is mainly developing a strategy and setting out broad principles and guidelines, but assigning all key operational decisions to others without creating any additional capacities. So this is important precisely in relationship to what Andrew Lakoff was saying, because for him, preparedness was a commitment to create new capacities. But that's precisely what has not happened in the context of the regulatory state, where preparedness is precisely not a commitment to more capacities, but a commitment to regulation. And so that's an important distinction. So rather than establishing authoritative control mechanism for emergency response, the department, so this is an example from the UK, the UK Department of Health essentially behaves as a meta-governor trying to steer other agencies to develop plans within its own loose framework. So the government, the state, mainly becomes a form of regulation, which is encouraging other institutions and actors to behave in a very particular way without providing any new additional capacities. Now, this is also happening on the global level. So the regulatory state, and this is important to understand, is not just a form of governance that happens on the state level, but it's also a form of governance that increasingly structures global governance. And the WHO might be one example for a global institution that behaves like a regulatory state. So Jones and Hameri say in relationship to global governance, globally the same dynamics manifested as a shift from international organization to global governance and meta-governance. Global governance does not strengthen or supplant states' substantive capacities, but mainly seeks to harmonize domestic policies and institutions, and thus placing the onus of substantive implementation on hollowed out states. I will just give you one example for this, and this is from the WHO. It's a document on the global influenza program, where they are supporting governments to develop preparedness plans, and this takes the shape of things like this: guidances, recommendations, plans, and so on. So here they outline essential steps for developing or updating a national pandemic influenza preparedness plan. So here you can see how this idea of regulation is at the heart of the way in which the WHO approaches the problem of pandemic influenza. So it's not trying to develop new capacities, but it's trying to regulate how states prepare for a pandemic. This is another page from the same report. Different phases are being outlined: steps, considerations, and tasks. But again, as you can see here, what is being provided is mainly a document, it's mainly a guidance, it's a checklist, it's a recommendation, and so on, but it's not an actual capacity. Now for states, this then becomes a problem not of building capacity, but it becomes a problem of compliance and reporting. So the regulatory state involves shifting the implementation and compliance burden away from state agencies towards entities being regulated. Now, for instance, a regulatory state is less likely to employ inspectors to enforce laws than to set out regulations and reporting mechanisms, with companies expected to develop internal enforcement capacities. So this is how the regulatory state operates. But in practice, this often reduces governance to a box-ticking exercise designed more to demonstrate compliance than to change substantive outcomes. So this is the shape that preparedness took in many different contexts. It took the shape of box ticking. It took the shape of compliance. It took the shape of reporting rather than building actual capacities that could be deployed during a pandemic. And the proposed solutions to the pandemic threat are constrained to the toolkit of regulatory governance, clear guidance, better communication, and improved coordination. So this is how the regulatory state thinks we can deal with the pandemic threat. It mainly frames it as a question of guidance, a question of communication, and a question of coordination. So when we go back to the Global Health Index security, we can see that this Global Health Index is itself an example of regulatory governance, right? Because what it does is it compares different states, it looks at what different states have done, and it requests states to perform preparedness and to demonstrate that the states have developed and thought about preparedness, but it doesn't really actually measure actual capacities, right? So what we see here is a kind of audit effect. Resources go into not improving healthcare capacities, but into the bureaucratic documentation of those capacities. To perform well in the audit becomes the main objective. And so we can say that the United States and the UK, what they did is they performed well in the audit, but performing well in the audit requires a very particular kind of capacities, and these capacities have nothing to do with preparedness as such. So I was just talking about the UK Influenza Preparedness Strategy of 2011, which is quite remarkable. So one of the things that you can read in that plan, which was published in 2011, 10 years ago, is that when planning for excess deaths, local planners should prepare to extend capacity on a precautionary but reasonably practicable basis and aim to cope with a population mortality of up to 210 to 350 additional deaths, possibly over a little as 15-week period, and perhaps half of these over the 3 weeks at the height of the outbreak. So why is this remarkable? This is remarkable because basically the government says, and the strategy acknowledges, that this is the number of deaths that you can expect during a pandemic. And it also mentions that the public expectation should be managed, and this should be taken into account as the most reasonable and most likely outcome of a pandemic. So in a sense, the pandemic, the UK government performed exactly as it predicted it would perform. Now, let me just conclude with a few thoughts. So I was saying before that we need to think and understand preparedness in the context of what I've called the regulatory state. So it is not the spread of the virus that has made lockdowns necessary. It is the regulatory state and its inherent failures that made lockdown the only available option in many countries. So the lockdown and the regulatory state are closely connected. The second important argument here is that the lockdown is not only a symptom of the failures inherent in regulatory governance, it is also the limit point of regulation. The ban of everything is the most extreme form of regulatory intervention, right? So when you think about lockdowns, lockdowns are not about building capacity. Lockdowns are a form of regulation. Lockdowns are the limit point of regulation because they entail the ban of almost everything. The second set of concluding thoughts has to do with the false binary between diseases of the North and so-called diseases of the South. The COVID-19 pandemic has clearly shown that infectious diseases are not just diseases of the South, but they're also diseases of the North. So the idea of an epidemiological transition from communicable to non-communicable diseases is very misleading, precisely because on the one hand, global pandemics reveal diseases that spread across borders, but also because there is a close interrelation between an interaction of communicable and non-communicable diseases, leading to mortality magnification. So COVID-19 is not just a problem of a communicable disease, it is also a problem of non-communicable diseases, precisely because people with comorbidities are much more likely to die from an infection with COVID-19. And the last point here is to remember Canguilhem, and he said, when we think about disease, we need to think about how life is situated within distinct milieus, and this milieu now includes the regulatory state and its pathologies, and this regulatory state is now present across both the global north and the global south. And so that's also one reason why the false binary between the global north and the global south is misleading. Now, there's also false binary between what's endemic and what's epidemic, because on one hand, vulnerability as an enduring condition is magnified by the waxing and waning of infectious diseases. So the epidemic and the endemic are closely related and interact with each other. And the second reason, the second important point here is that epidemics are not a narrative, as Charles Rosenberg has said. They don't have a beginning, a middle, and an end, but we should think about epidemics more as a force with a rhythm, a pulse without beginning, middle, and end. So we need to move beyond understandings of epidemics that focus on dramatic and episodic events and highlight instead the longue durée of pathology and the structural conditions that are responsible for dramatic outbreaks of disease. This will require a different temporal sensibility for work that is more timely, precisely because it is untimely. So the argument here is that it's important to move away from this idea of epidemics as events and rather look at the interrelation and the interconnection of the endemic and the epidemic. So how can we think Corona beyond beginnings and endings? This is a graph that might seem similar to you, but the interesting thing here is this is a graph from 2005, which shows the number of human coronavirus samples per month found in 50 samples from patients hospitalized for acute respiratory symptoms. The point here is that coronaviruses have been circulating in humans for a very long time, and the latest virus that has been spreading is just one more virus in a whole range of other coronaviruses that have been infecting human populations for a very long time. So here again, you can see that though we might think that the COVID-19 pandemic has a clear beginning, actually that beginning is not so clear, and we could tell other stories that have other beginnings and that have other endings, and that would be stories that are more stories of endemic infectious diseases rather than epidemic infectious diseases. So I just want to close here, and I'm looking very much forward to your questions. All right.
Thank you, Carlo. And I think I just want to make a few opening remarks, and there are lots of interesting comments in the chat box, which I'll highlight. I think firstly that you started with the pandemic preparedness for influenza in the United States, and clearly the very definition of preparedness itself is something that you problematize, because I think in much of the documents you showed on your screen, preparedness in the American context has always meant the responsibility that individuals have to take for the preparedness. And then there is the delivery of the technology, because don't forget, there was a huge market for influenza vaccines, which have become a routine part of the medical culture in the United States. And so that was, in fact, to me, very interesting, and it leads to many of the reactions that the document that you presented on the Global Health Index, and how does America come right on top for a preparedness, but has one of the worst outcomes in the world. And I think that several people who have raise this. So what is the way in which you measure preparedness becomes a very interesting question, and maybe you can throw a little bit of light on how the weights were given, or maybe we can do it later through email. But what really intrigued me was also this concept of the regulatory state. And, you know, clearly we are talking about post-health sector reform all over the world, and the context in which health systems have been highly commercialized. And one of the things that the COVID pandemic has thrown up very clearly is the kind of fault lines of not having strong public health systems across the globe. One, that, and two, even countries that had very strong insurance schemes, you know, the important story there is that if you have a hospital-based health service system, what does it do? If you take Lombardy as an example of being one of the richest provinces in Italy, having the best hospital system, but they couldn't quite handle the pandemic. So it raises this entire question of what kind of a public health system have we sort of moved across the globe to. And I think Vanita has a comment on the chat box saying that even within India, Kerala stands out as a different example of how you can be prepared for a pandemic in the Indian context. But one of the reflections I had from your presentation is the Indian context, to me, in a sense, knits what Prashant's lecture did and you have presented, which is a combination of continuities of colonial policies and those the acts that were being evoked to even bring centralized control, like a lockdown or other measures of containment, was an exercise through the legislations that were available in the colonial period. And then the disaster management, which also has these very, very centralizing tendencies of how to handle a pandemic. But it also had elements of a regulatory state. But in that, there was really very little references to drawing in, say, the private sector to build capacities. And therefore, you actually, and this is what Ravi has commented in the chat box, you basically threw the entire responsibility to state governments. So it became, there was so much variance in how state governments could actually respond to the COVID pandemic. And even during the lockdown, the efforts to build capacities, there was really no systematic effort to build those capacities. And of course, the vaccination story is showing you yet another facet of this. So, I mean, I think some of these questions have been more like comments have been raised. And if anybody has specific questions to Carlo, please do raise them. And maybe Carlo can also respond.
Sure. Thanks, Rama. I mean, I completely agree with your analysis of the Indian scenario, which is a kind of a mix between a regulatory state and you know, a different kind of state, one a post-colonial state, but also you know, a kind of modernist states still invested in building certain types of capacity. So especially in the context of vaccine production, India has been at the forefront of both producing vaccines and exporting vaccines. And so that is definitely not an example of a regulatory state. But nevertheless, it has imposed a lockdown too. But I think in India, the lockdown was imposed for a number of other reasons, which have to do with authoritarian politics and, you know, and so on. So what you were saying about the different states is also absolutely correct. And I think that makes the picture even more complex.
There is a comment from Prashant. He said, I think Carlo's final point is an excellent one about the relationship between event and structure, the epidemic and the endemic. I think we need to rethink our sense of what an event is. I think that the event seen purely as a momentary disruption needs to be reframed. We need to consider events as being fundamentally transformative of structures. Purendra also has a question. In the current pandemic, regulatory state has provided greater flexibility for private actors to enter and exit in terms of interventions. What is your response?
These are excellent comments and questions. Now, when you look at the UK example, the UK has outsourced a lot of its response, but the way in which it was outsourced to companies who very often had no expertise whatsoever in pandemic preparedness in terms of responding to epidemic events and so on. And very often these companies failed short to deliver on their promises. So a lot of money was wasted in just unimaginable ways. Some of you may remember that the UK tried to establish a track and trace system and has spent billions of pounds on establishing such a system through private-public collaborations, through outsourcing, and so on. And it took the country over 9 months to establish such a system at a point where it was already too late for it to make a difference. So I think, you know, when you look at the paper that I was mentioning, you would see much more examples of what a disaster this way of governing the pandemic in the UK has been, not only in terms of the people who have been infected, the people who have died, but also in terms of how public resources have been wasted with little effect for the benefit of population.
Carlo, there's a question for you. When the Global Health Security Index came up with its list, was a counter voice or list generated then, or was it largely accepted?
I think it was largely accepted. I didn't see any people criticizing the account or asking questions. See, one important thing to keep in mind is that this idea of preparedness, at least within the world of public health professionals, has become so hegemonic that very few people have been asking questions, right? Because it sounds like a great idea, right? When you say we should prepare for a pandemic, that no one would disagree with that. Everyone would think that's a great idea, that's what we should do. But the important point is to understand the logics, the rationalities, and the structures. The important point is to understand, well, what does preparedness actually mean? And as I was saying before, the way in which preparedness should be understood, it should be understood as one form of the regulatory state, as one form of dealing with disease that becomes hegemonic in the context of regulatory states. So it's not itself a different type of rationality, but it's just another illustration of how the regulatory state works and how the regulatory state tries to address social problems, but constantly fails to address these problems, precisely because of the key pathologies that are at the heart of the regulatory state itself.
There's a question from Meera Shiva. Besides presence of good public health systems in Kerala, according to Social Watch in Uruguay, in Latin American region, countries with least inequity did better. What is your view on this?
That is for sure the case, that you know, a country, a population where there are less health inequalities, where access to healthcare is easy and is accessible, that of course will have a better outcome in terms of the pandemic. I think that's a key element. But even though the UK has a national health system, that doesn't mean that the system is accessible or that it's providing equitable healthcare to all. Right? It has itself limitations, and it has itself.
Has there been any critical writing around the preparedness document that you shared with us?
The paper that I was just mentioning before in terms of the regulatory state and preparedness, I think is the most acute analysis that I've seen over the last year. I think it's just you know, the coherence of the analysis, the way in which it uses Britain as an example, and the way in which it explains the total failure of the British response is in my view, the most acute analysis of what has happened over the past year. And of course, Britain is an extreme case, but I think it applies to many, many other countries as well, especially countries which have the most neoliberalized forms of governance, such as the UK, the US.
There's a comment from Anne Emmanuel Byrne. She says, fantastic analysis, including the critique of epidemic pandemic as dramatic narrative. I was wondering if you could return to your concluding thoughts slide and further problematize lockdown, since they were used in different forms in socialist and neoliberal states.
Right. I completely agree with that. So lockdowns were used and implemented in different parts of the world, but of course they have different meanings and different implications. So the lockdown in India had a different, form. It had a different implication. It had a different impact compared to lockdowns imposed in other places. What is often being forgotten is that China never implemented a national lockdown. So even though China is always seen as the most interventionist country, actually China never imposed a national lockdown. What they imposed was a regional lockdown in Wuhan, which focused mainly on cities. So when you look at the total population of China, only about 4 or 5% of the population in China was in a lockdown. So the idea of the national lockdown was not invented by China, it was invented by Italy. Italy was the first country which imposed the national lockdown, and that was a very different strategy compared to the one that China promoted. So that's just, and then, the lockdowns took very different forms. Sometimes it was a very militarized form, sometimes it was more like a police intervention rather than a public health intervention. Some lockdowns were very strict, some were less strict. So it's important to pay attention to these differences and understand how lockdowns were imposed, how they differed from each other, and what were the reasons for imposing these lockdowns. As Rama was saying before, Lombardy, the region in the north of Italy, is one of the richest regions in Italy, but it's also one of the most neoliberalized regions in Italy, where the healthcare system has been most neoliberalized. And I think that's precisely the reason why the lockdown, or why the COVID-19 pandemic had such a dramatic impact in that region in particular.
Vanita Mukherjee has a question. She says, but China did not have to impose a lockdown. They had other strategies that achieved the purpose of a lockdown.
Well, that may be true, although I think, I'm not quite sure what other strategies this might refer to. Does it refer to strategies of testing? Does it refer to strategies of surveillance? I'm not so sure. I mean, there's definitely the case that South Korea has been extremely successful in terms of its response to the pandemic. And it's precisely because the response was based on actual existing capacities and rather efforts to regulate other agencies and to outsource capacities and to try to deal with the pandemic by coming up with plans and guidances and recommendations, right? There were actual hospitals, there were actual laboratories, there were actual stockpiles, there were actual capacities to produce personal protective equipment, et cetera, right?
Yeah, I think we've had a very, very interesting and a very lively discussion with both presentations, and I think they complemented each other very well. I think, Carlo, you have sort of tickled our sensibilities and interest in really looking at this GHI carefully. And I think this issue of the endemic and epidemic as being, and pandemic as being, you know, discrete events is something that I think will be very useful to problematize, because after all, the conditions for spreading of a lot of the communicable diseases are there, and they're continuing to be there, and inequality is an issue. So whether you're, you know, whether you're looking at the UK or the USA, or you're looking at, you know, India and South Asia and Africa, I think you're going to be dealing with very, very similar kinds of questions. So COVID is here to stay for a while. It may recede, but then something else will come up. So, I mean, I think we need to rethink this issue. And thank you, Sama, for asking me to be a part of this conversation. I think it's been very, very rich. And thank you so much. Over to you, Sarojini.
Chayanika, what to say?
I don't have much to say. I have much to think, actually. Yeah, I really would like to thank both Prashant and Carlo for, as Rama said, for connecting. We can see the connections in the two presentations and also differing questions that are coming up from both. And I think it's very interesting to start rethinking how do we look at the pandemic from now on, because even if we've forgotten the past, we need to remember that this is something that's going to continue with us. So thank you very much. And we hope that this conversation amongst all of us shall continue to, you know, think of the paths forward.
Thanks, Chayanika. I don't have much to add. I'm really looking forward to, you know, these conversations, and there is a lot which we've learned, and then maybe we need to reflect and rethink, revisit some of the things which we are experiencing within the country. Thanks to all of you. And Nilanjana, can I invite you to close the session?
Thank you, everyone, the speakers, the facilitators, and the participants who joined us today. Many of our friends who had varied time zones couldn't join us, but we assure you that the recordings of these conversations will be on our website soon. Our next conversation of the series is with Dr. Eugene Richardson on 16th April at 6:30. He is from Harvard Medical School and also the author of Epidemic Illusions. We will be sharing the announcement soon with you all. Thank you once again on behalf of Sama and PHM Gender, Justice, Health and Thematic Group. We hope to see you again in our next conversation as well. Have a good day.